Good morning. I'm Angela Cornelius, and I'm here to talk to you this morning about opiate use disorder. So let's talk about some objectives. Like, what do I want you to be able to do? I want you to describe the mechanism of action of opiates at a high level. We're not going to go super deep into the molecular basis, but at a high level, I want you to be able to identify the spectrum of presentations of opiate use disorder. I want you to contrast the treatment options for opiate use disorder. And I want you to summarize the MIAMSA MOUD program. Sorry, Levi, I'm gonna start all over again because this is what I do. Right. Good morning, I'm Angela Cornelius, and I'm here to talk to you about opiate use disorder. So let's talk about the objectives. What do I want you to know and be able to teach me and tell me after this lecture? So I want you to be able to describe the mechanism of action of opiates. And we're not talking about at the molecular level, we're talking about at a high level. I want you to identify the spectrum of presentations seen with opiate use. I want you to contrast the treatment options for opiate use disorder. And then we're going to be able to summarize the MIAMSA MOUD program. So why is this important? Why are we even talking about this, right? So look at these numbers. These are the increases in opiate use since 2004. You can see buprenorphine has increased by almost over 2,300%, which is super interesting because buprenorphine came out in the late 1990s, and it was licensed as a pain medicine, but they found a lot of diversion of this drug happening. And so it was rebranded as a treatment for opiate use disorder. And that was in 2002 when it first became FDA approved. And so since 2004, you can see it's gone up by over 2,300%. So people are using it for this. Fentanyl, 35%, hydromorphone, methadone, morphine, oxycodone, which we hear a lot of people ask for oxys. And interestingly enough, use of codeine actually decreased by 20%. And I suspect that has to do with the fact that it's a less effective pain medication overall. And then there are a lot more side effects and a lot less good benefits. So let's talk about how pain is transmitted. So it starts out here in the periphery, right? You get this noxious stimuli, and then it's transmitted through your sensory neurotransmitters into the dorsal horn of your spinal cord, and then transmitted up your spinal cord to your brain, where your brain interprets this as pain. And so let's talk about what happens with pain stimuli and then how opiates block this. So the regular pain stimuli, you're going to have stimulation of this nerve, and then it's going to release neurotransmitters to the next nerve, which is going to cause this nerve to fire, and it's going to go on. And these are in your peripheral nerves here. So what happens is opiates come in and they bond to this receptor. You're going to hear the mu receptor most of the time, but there are a lot of different ones, and it blocks some things and it increases some other things. And the net effect of what you get is that it blocks these nerves from firing, and it blocks these nerves from putting neurotransmitters between them. So therefore, it pretty effectively blocks the pain pathway. And so here's just kind of all I want you to take out of this is that there are a lot of different receptors, and opioids can act as both agonists, antagonists at multiple different receptors. And these are the three most common, but there are probably 5 or 7 at least. And so let's talk about agonist versus antagonist. So here's just your natural receptor site, and you have natural endorphins that will actually help these sites, also natural pain decreasers. So they'll fit in this receptor site and you get this normal cellular activation. So you have this agonist drug. Well, agonists come in and super activate this. So they bond to this super well, and it's like adding an espresso shot to your coffee. It makes the effect much more. And then you have these antagonist drugs, and they come in here and they fit in this, but they don't activate it. They just block it. And so you block all of this cellular activity. And so over here, this would be like your naloxone. And then this would be like your opiate drugs. And then we're going to talk about buprenorphine in a little bit, that actually acts somewhere in the middle of this. And so this is a chart looking at how different opioids activate these receptors. And this is really important for you to understand because see up here, you have fentanyl, right? This is a super agonist. Well, what does that mean? That means fentanyl bonds super tightly to these receptors. And that's why fentanyl will actually take significantly larger doses of Narcan to push it out of those receptor spaces and be displaced. So that's why fentanyl overdoses take a lot more Narcan than, say, over here, your full agonists, your morphine, your heroin, the things that we're commonly going to encounter. And then over here, you see where your buprenorphine is. It's a partial agonist. It's an agonist, partial agonist, which we'll talk in a little bit and we'll show you kind of the mechanism of how that's going to work. But so it helps. What it does in that case is it actually decreases the cravings, it decreases the pain stimulations, but it also doesn't activate some of the other more noxious stimuli that you'll sometimes see. So let's talk about buprenorphine. So buprenorphine comes in and it actually has a pretty high affinity for the opioid receptors. So it will actually displace your opioid. And heroin's what they used in this gram, but it's any opioid it's going to displace. So what happens when you displace the heroin and you don't have anything stimulating that? So what happens is withdrawal, right? And we're going to talk about some of the symptoms you'll see in withdrawal, but that's why it's super important that we score these people for how much withdrawal they're actually in, because if they're not in enough withdrawal, we can actually, with this medication, push those opioids out of that receptor and actually induce withdrawal and make people pretty uncomfortable. So let's talk about the spectrum of opiate use signs and symptoms. And in order to get to this, we sort of have to talk about the concept of tolerance and drug dependence. So over time, you have repeated exposures to higher and higher doses of opioids. So the brain chemistry actually changes. And so what happens is a brain without opioids no longer can function normally because it has gotten used to having that. So there are two things that come from this. One is you can get opioid tolerance, which is the need for increasing amounts of the drug to cause the same effects. And then you can also get, pardon me, drug dependence. And this is when people actually become dependent on this. So in other words, they are going to have withdrawal if they don't have the drug. And so withdrawal symptoms can only occur in those patients who have developed this tolerance. And then there's another concept that we sort of need to know about: opioid tolerance and opioid-induced hyperalgesia. So these are problems that you get when people are under chronic pain management usually, or if they're chronic users of opioids for other reasons. So tolerance is, again, the state of adaptation where you have basically the receptors. When you flood your opioid receptors, they actually downregulate. Your body's pretty smart. It's like, hey, there's a lot of that out there. We're going to downregulate these receptors. So it does actually take more opioids to get the same effect because there are less receptors now. So, and then you've got this concept of opioid-induced hyperalgesia. And these are the people that will have what seems to be relatively minor pain, and they just have a hyper exaggerated response to it. And they've just basically become where they cannot tolerate the same amount of pain anymore. And they're not sure about the exact mechanism of action, but they believe it does have something to do with potentially the downregulation of these receptors. And so when you see these patients, they are often actually in extreme pain. And I know there's a perception that they're trying to get high or that they're drug seeking. And most of these patients do actually legitimately have pain, and they do actually legitimately require larger doses of narcotics to actually get pain relief. So just keep that in mind. I know there's a significant bias about this, but there are physiologic mechanisms why these patients actually do have pain. And so how does the changes in the brain begin? So let's go back a little bit. We talked about there's some changes in the brain. So when people take morphine or heroin or some sort of opioid, it's going to enter your central nervous system, and it bonds to your mu receptors here too. And we talked about the mu receptor back in the peripheral nerves. It's in the brain too. But so the mu receptors actually are linked to your reward pathway. So through a bunch of complex physiologic signaling, it actually ends up releasing dopamine, which is kind of your feel-good neurotransmitter in your brain. And so this causes pleasure, and your brain is wired to, if something caused it pleasure, it's wired to pursue that again. And so this is how your opioid addiction begins, is that you get this pleasurable feeling, this release of dopamine, and you chase that again, but it's never quite the same with the next time that you have the opioid. And you don't need to know all of these little acronyms and all that. Just know that there are pleasure centers in the brain, and that is how opioid addiction occurs. So let's talk about opiate intoxication. So these are just the people that are on opiates that are doing okay, that, you know, they're just intoxicated with them. So some signs of intoxication you might see analgesia, so they're not feeling any pain. They may be kind of euphoric, just kind of happy, miotic. Now, this isn't 100% an opiate intoxication, because your chronic users, your pupils will actually adjust to this, so they might not be as miotic as you would expect. Constipation, sedation, red, itchy eyes, slow respirations, less cough, sleepiness. They might also be known as on the nod on the street. And then you might actually see bradycardia and hypotension. And this is all within the realm of opiate intoxication. So now let's move on to opiate overdose. And we all know what this looks like, right? They're not responsive to us. They're not breathing, or they're breathing 3 or 4 times a minute. You might hear sonorous gurgling respirations. You might see cyanosis in the fingers or around the lips. And in this case, you will likely see some miotic pupils, because when you've gone to overdose, you've had a significant amount of opiates deposited. And so it is quite likely that even if the pupils have adjusted in an intoxication, that you will still see miotic pupils. So when do you need to give Narcan? And I've been reviewing charts, and so here, straight out of our protocols, you know, up here we have the intranasal for the assist, and down here we have the IV Narcan. And so you notice there are 3 things. Suspected opiate intoxication is first, and then we want to see meiosis, respiratory depression, and CNS depression. So in other words, they're altered, they're not breathing normally, and they have teeny tiny pupils. Those are the 3 things we want to see before you give Narcan. So in reviewing charts, what we've noticed is there's a lot of Narcan being given in cardiac arrest. So I pulled out the protocol. This is directly out of our protocol book. Where do we see Narcan on this protocol, and why don't we see it? So let's logic this out, right? So the cardiac arrest was not caused directly by the opiate, right? It doesn't bond to anything in the heart. It doesn't cause a dysrhythmia. What caused the heart to stop? The heart stopped because they stopped breathing, so they stopped getting oxygen, so they had an hypoxic event that caused the cardiac arrest. So logically, if you give Narcan when you have an advanced airway, a King or an endotracheal intubation, or you're BVMing with good end-tidal CO2, good ventilation, then would it make any sense that giving Narcan is going to, at that point, help? No, because you've got the airway, you're taking care of the hypoxia that caused the cardiac arrest in the first place. And just recently, the American Heart Association came out and talked about this, well, about a year ago. And the long and short of it is the literature is mixed. And if you get out there and you look at it, there is literature all over the place that maybe it's beneficial, maybe it's not beneficial. We haven't teased out if it is beneficial at all, but we have seen that there are some potentials for harm. So what the American Heart Association says is, because there is this theoretical basis for harm, if you have somebody that's a suspected opiate overdose, standard resuscitation alone is indicated. So at this point, that's where we're at. And that's why we don't have Narcan in the protocol, is because there's this benefit risk ratio that we look at, and it looks like there might be risk, and there's no benefit that we can tell at that point once you have an advanced airway. So let's talk about opiate withdrawal, right? This is pretty much the opposite of everything that you see with opiates, right? Instead of constipation, you have diarrhea. They're super sweaty. They're vomiting. They're sweaty. They have big pupils, like big, huge pupils. They have goosebumps. They may be cramping in their abdomen. They're having cramps in their legs. They're having diffuse joint aches. And we'll talk, all of this goes into the scoring system for actually how we figure this out. So here's your opiate withdrawal timeline. So over here is where you stop. About 72 hours is going to be your peak of symptoms. They're going to feel super bad. Like they're going to feel like they have the flu, just chills, fever, body aches, diarrhea, vomiting, like dilated pupils, like they feel awful. At about a week, they start to feel better, but they're still tired. They're still sweating. Their body is still wanting that drug that they had for all that time. And so your body's still adjusting to re-upregulating those receptors and kind of figuring out how to function without it. At about week 2 is where the physical stuff it's gone. But there's a lot of psychological and emotional symptoms. And you see this with any sort of thing that you're using, such as smoking. You will see this psychological and emotional symptoms, and that can go on for a long time. The same thing happens with opiate use disorder. And then out at about a month, they might still have a few physical symptoms, but for the most part, it's just going to be this psychological cravings and depression that will go along. So how do we score this? So this is the COWS score, which is the Clinical Opiate Withdrawal Scale. And so here is this, and we're going to go over each section, so don't be like trying to strain and read the screen or anything like that. So let's go through each of these sections. So resting pulse rate. So we're looking at, 0 is if they're not tachycardic at all. If they're getting up towards tachycardia, they're a 1. And then if they're greater than 120, they're a 4. And then are they sweating? And some of this will be, they report that they feel really flushed and hot. To an objective, like you see them wiping their brow, they've got sweat streaming off their face. So this can be subjective and objective information. Are they restless? Like, can they sit still? Like, are they sitting here just like me, other than I move a lot and use my hands? But are they like sitting here just chilling? Or are they just all over the place and they can't sit still and they're pacing? What do their pupils look like? If they have teeny tiny little pupils, you've got to worry that they have opiates on board, and you don't want, if they still have opiates on board, you do not want to try to precipitate withdrawal. You don't want to do that. Or the opposite of that, their pupils are so dilated that you can't even tell what color their irises are. So bone or joint aches, and they may tell you, like, I have diffuse body aches, I feel really bad. They may like rub their muscles or their joints. They keep moving around because they just seem uncomfortable. Runny nose or tearing. They may sniff during the exam, or they're having to blow their nose constantly, or it just looks like they've been crying because there's tears running down their face and there's snot running out of their nose. GI upset. Have they been vomiting? Have they had stomach cramps? Have they had, have they not been able to leave the toilet because they've been vomiting and having diarrhea so bad? So tremor. How do their outstretched hands look? If they reach for something, are they shaking, or are they pretty stable on how their hands are held? So yawning. Do you see them yawning during observation? And this is one where you're either going to see it or you're not going to see it. And then anxiety or irritability. And this might be the patient that tells you they're anxious. So they might be a 1 to all the way to 4, where like maybe they're not like telling you that they're anxious, but their eyes are darting all over the room and they're pacing back and forth. And like it's very clear to you as a clinician that they're anxious. And also goose flesh. So the skin is smooth. Piloerection can be felt, or like you see, and when they say piloerection, that's like, goosebumps, like when you get really cold. And I just wanted to say, don't worry about having to know all this. We're going to have further training as our MOUD program rolls out. And eventually we want you to all be able to recognize withdrawal so we can help get these patients on the appropriate medications and get the appropriate help they need. So let's run through some cases. So you have a 35-year-old male. He calls for diffuse body aches, nausea, and vomiting. His last oxy use is about 24 hours ago. Here's his vital signs. So he's pretty tachycardic. He's visibly sweaty and he's rubbing the sweat off his face as you're talking to him. He's blowing his nose constantly. He's pacing and restless, and he stops and he's like rubbing at different ones of his joints, like his elbow and his shoulder and his knee. His hands are pretty shaky, and you can see visible goosebumps from across the room. His eyes appear to be black because his pupils are so dilated. He'll answer your questions, but he never finishes the answer as he begins to pace again. So let's score his cows. So I pulled out over here the clinical symptoms that are relevant for cow's score. So he's got nausea and vomiting, heart rate of 130. He's visibly sweaty, pacing, blowing his nose. He's rubbing his joints. He's got tremors in his hands. He's got goosebumps. He's got large pupils. So let's score this. So the nausea and vomiting, like I'm going to go with a high score on that one. He's pretty tachycardic, so he's definitely a 4. He's visibly sweaty, like he's rubbing this off his face. He's pacing and restless. I would call that pretty restless, right? He's blowing his nose, frequently stops to rub one of his joints. His hands are noted to shake. He's got visible piloerection or goosebumps. His pupils are huge. His eyes are so big, you can't even tell what color his irises are. And he's just anxious, like clearly he's anxious. He doesn't tell you he's anxious, but like he's pacing, he's looking all over the place. And then you give him a 0 on yawning. You just don't see that. But if we put all this together, like his cow's score is a 44, and you need to be at an 8 or above. So clearly this guy is very well into withdrawal. So let's look at a little more subtle case. So you have a 22-year-old female who calls for EMS because of anxiety and nausea. She doesn't know what happened, but 2 days ago, she began feeling anxious, having diffuse body aches, and just feeling like her face was really warm. She's sitting still, but you notice her eyes kind of dart all over the room, and she seems to startle at loud noises. She periodically yawns during your assessment, and then you notice she's sniffing. She's not blowing her nose, but she's sniffing and clearing her sinuses a bunch. Her skin appears smooth to you, but when you feel it to put on the blood pressure cuff, you notice that it feels a little rough. And then here's her vital signs. So let's score her cows. So I would say she's anxious, right? Like she tells you she's anxious. She reports anxious. So she's sitting still, but her eyes are darting all over the room. I would call that, along with restlessness over here, which actually I think I may have scored it differently. But so nausea. And then she's telling you diffuse body aches. So subjective reportive chills or flushing. Her saying her face is warm is probably flushing, and I would go with that. She's periodically yawning. She's clearing her nose, so she's got some nasal stuffiness. Her skin appears smooth, but you can feel the goosebumps when you put on the blood pressure cuff. She's mildly tachycardic. So she's able to sit still. So I would call the eyes darting, could be restless. So if you wanted to score that one up, that's sort of one of those gray areas. Her pupil size is normal, and you don't note any tremor. But that's a 14. That's still a 14, and she doesn't seem like she's that bad, right? And it's not uncommon to have patients tell you, I don't know what happened, and not admit that they were pretty heavy opiate users. So let's talk about our program, my EMSA's MOUD program. So this is where we are right now. So right now, we're finding these patients, we're pulling their records within 72 hours. We're trying to get out to them and get them hooked into resources. The JPS Bridge Clinic, we're providing naloxone and naloxone teaching and resources for medication-assisted treatment. So stage 2, so it's going to add those things highlighted in red right there. So if we blow them up, you notice it adds a telehealth visit and a field induction if cows are greater than or equal to 8. We haven't worked out all the details for exactly how this is going to happen yet, but that's hopefully we'll be rolling out this stage in the next month or so. So here's stage 3. And you notice down here, we're going to start adding where all of our EMS crews are providing an naloxone kit, and they're teaching patients and their families and friends, if they refuse transport, how to use that. And even if they don't refuse transport, if they're not going to a hospital that supports providing Narcan rescue kits, then we're going to go ahead and make sure they have one. And then in stage 4, you add a couple of different things. So up here, now we up the ante, right? The MIH team, within 90 minutes, we want to get to these patients and we want to provide them this Narcan kit. We want to try to keep them from overdosing and causing their death. And then the resources for medication-assisted treatment, which actually MOUD is medication for opioid use disorder. And medication-assisted treatment's a little more broad term, which would cover other medications, although we're only targeting opioids. And then down here, it also adds in, this is where it's going to be important for you guys to understand the COWS score. So out in stage 4, we want you to recognize withdrawal symptoms. Maybe somebody just calls you for nausea and vomiting, or diarrhea and vomiting, and you get the history and you see all these other things, and it dawns on you, wait a minute, maybe they're an opiate use disorder withdrawal. So it's going to hopefully be able to lead to a telehealth visit and field induction if COWS are greater than to equal to 8, with referral to the outpatient clinic. So this is where we would like to be by the rollout of this program, where we're getting to the patients and we're getting them the care they need appropriately in a timely manner. So eventually, we're working with IT to get a button where there will be an easy referral for MOUD. We're not sure of the mechanism that's going to happen, but it should be coming to a screen near you. And that's it. Thank you very much for your attention. And here are my references. Thank you.